As I was mentioning, it's great to see on this gorgeous morning, although I was told we may be getting a storm later, but this is a beautiful, April day, and I was thinking on my way to campus this morning that April is always such a special month, right? Not only with projects and exams, but it's really a month of new beginnings. Right? Nature is happy, it's blooming, graduations are near, and it's also a month during which we celebrate National Public Health Week and recognize all of the wonderful work that public health professionals in our nation and across the globe do on a daily basis. And our guest this morning, Dr. Jackson Williams, exemplifies those great qualities of what a true public health professional is. So let me just share with you a few highlights about Dr. Williams. Dr. Williams is a pediatrician by training. He is currently assistant professor of pediatrics and director of the division of pediatric hospital medicine at the Quillen College of Medicine and the Children's Hospital. He holds a medical degree from the University of Tennessee Memphis School of Medicine, and he completed his residency training in pediatrics at Bay State Medical Center in Massachusetts. Interestingly, he also holds a diploma in tropical medicine and hygiene from the Liverpool School of Tropical Medicine in the United Kingdom. But the main reason that Dr. Williams is with us this morning is because he is a global health educator who is very passionate about sustainable global health and about quality improvement and health system development. So he lectures frequently on a range of global health issues, including disease management, malaria, measles, Ebola, and other infectious disease management, as well as on health system development, particularly post-conflict or in post-war countries. In 2015, he founded the Global Health subsection of the American Academy of Pediatrics, and he currently serves as the co-chair of this subsection. His presentation today, titled Beyond Medical Tourism Towards Informed Global Health, as I'm sure you were able to tell from the title, is really intended to encourage us critically to think critically about global health issues and about long-term solutions to pressing health problems facing our world. So with that, I will turn it over to him, and please join me in welcoming him.
All right, thank you for that very kind introduction. Glad to be here with you all this morning. All right. As often we'll do in talks, I just want to be clear, I don't have any financial disclosures and no conflicts of interest. The one caveat I will put on that lovely introduction is I'm primarily a clinical pediatrician. I am going to talk about, I would say, if I had to label myself as having an area of expertise, it's probably more around being a pediatric hospitalist and running a pediatric hospital program here in the U.S. But the thing I am passionate about and have tried to do a lot of extra self-education on is around issues of global health and some of the intersections of public health and global health that we'll talk about today. So where are we going this morning? Just so it's not open. Cool. I'm going to just share with you why should we care about global health, particularly here in East Tennessee, where we're at a public university that's really geared towards helping people in rural Appalachia. And so I'm going to talk to you and hopefully convince you that global health is important to all of us. My background, global health, just a little bit about that. And then just a quick overview of some of the global health agencies and some current issues in global health. and then just finally some guidelines for responsible and informed global health experiences. And then, of course, time at the end for questions and answers. So why global health? So I'm going to share with you some of the reasons that I can best articulate why I think global health is particularly important. So this is a cool piece of software. I'm a bit of a map nerd. I'm obsessed with maps, but I think they're really interesting and tell really helpful stories about the world, and often in a visual way that's more helpful than just throwing lots of facts and figures and quick statistics at you. So this is a website that y'all can go to called World Mapper, and you can see the partners who helped develop this website. But what it does is it increases or shrinks the size, the geographic size of a particular country based on statistical parameters that they put into this software program that they developed. So like I said, I think it's a helpful visual representation. So to start, this is what the population of the world looks like if you sort of put it into the World Mapper software. And you can see, as you might expect, places like China, India, and Japan blow up relative to their relative geographic size based on the population the countries have, and places like Canada and Russia tend to shrink because they've got a large territory, but not as large a population. And at least for me, one of the reasons I care so much, especially as a pediatrician about global health, is this is what the graph looks like for death rates, for mortality for children under the age of 5. And you can see sub-Saharan Africa in particular blows up. India, partially because of its very large population, blows up quite large. And other parts of the world shrink, like Europe, Canada, US, etc. And so as a global health practitioner and someone who cares about health of the children worldwide, if I have to think about where are my services most needed, this representation for me at least sort of gets me engaged in that process. Oh, I'll also point out Haiti, which is the poorest country in the Western Hemisphere, also has very high mortality. And this is the physician workforce. So these are where doctors in the world work. And again, you can see we have a gluttony of doctors here in the US and in Europe, but sub-Saharan Africa, which is pictured down here, almost vanishes off of the map. And again, better than, I think, throwing at you lots of stats and numbers, this to me represents why global health is important for the world's poorest countries. But those arguments don't often win me favors when I'm talking to hospital administrators and other folks. So, I often have to make other arguments to folks wearing the suits. And so one of the things I share with them is that, and this is certainly true, students who participate in global health, as you might expect, report better cultural competence. There's a big advantage to that sort of cultural exchange. It's often really helpful for universities to recruit top-notch students. A lot of students now are very interested in traveling and seeing other parts of the world, and so that's often very important. And then, at least for me in medical practice, and I think this is one of the arguments I make here at ETSU, is global health track. So resident physicians who take a path where they do extra training and experiences in global health are actually not only more likely to serve abroad in low-resource countries, but they're also more likely to work in underserved populations here in the U.S. So they're more likely to stay in the U.S. and work in places like rural Appalachia or underserved inner city populations. And that's been shown by a couple of studies. And this is the third reason I get people to sort of think about how global impact, how global health impacts all of our lives. So this is a father, and he's holding a picture of his wife, one of his children, and another child back here is Emil that's pictured in this photo. And Emil was a 2-year-old boy who grew up in a very poor and isolated part of Guinea. Hard to reach, hard to find on the map unless you know what you're looking for. And Emil, like the other boys in the village, played in this really large hollowed out tree. And they would go there and use it like a fort or a cave. It was a really cool thing for a 2-year-old boy to do. Unfortunately, in December of 2013, Emil came down with a mysterious illness, and he had vomiting, diarrhea, and seemed very, very sick. And he actually passed away within a couple of days of contracting this illness. A few days later, Emil's mother and his sister both got the same illness. They too passed away. Then Emil's grandmother got the very same illness as well, and she passed away. And unfortunately, they lived in a region with poor access to health care. The hospitals where they could go to be seen were very understaffed, overcrowded, and other people ended up getting this strange, mysterious illness. Does anybody have any idea what illness I might be talking about?
Like without cheating, without.
Oh, and is it in small print? I should have covered it. So I heard someone say it. Yeah. So this Emil is actually thought to be, and Emil's father, they're actually thought to be the index case 0 for the Ebola outbreak. And think about how that Ebola outbreak in 2014 primarily impacted people's lives, even here in the U.S. People were freaking out here in the U.S., right? They were worried that it was going to be like the end-time zombie apocalypse type thing, right? So, you know, and working in the health systems, I had to do emergency Ebola preparedness training. I spent hours learning how to properly put on Ebola equipment in case we were to have Ebola patients. I was practicing in Massachusetts at the time, and a doctor who I've worked with actually contracted Ebola and came back to Massachusetts. And so we had to be prepared for that sort of thing, but it impacted, you know, pretty much any healthcare worker in the U.S. and worldwide. And the reason I point that out is our world is interconnected now. The next disease outbreak is but a plane trip away. And so the healthcare and the health systems that impact a 2-year-old boy living in rural Guinea can directly impact our lives and what happens to us here in America. So that's the final argument I make about why this is all so important. Whether you believe existentially, spiritually, that we're all interconnected in some way or not, in a very real way, from a very real public health perspective, we are all interconnected, and these things do link up. So that's my argument for global health. Before I proceed any further, I'm just curious, has anybody been on a medical mission trip before? Anybody done any health work worldwide? Anybody grow up in countries that have been under-resourced that are now coming here for further training and education? Okay. Just curious. So, well, good. So I'll share just a little bit about my global health journey. I'm always a little bit wary of talks that spend a lot of time where the speaker talks about all the cool things that they've done. So I'll try to keep it to a minimum, but I understand that's part of this forum. But I did want to share this. I grew up here in Johnson City, and I'll talk about that. Primarily, I've worked in India. This is part of India too, although it looks like it's in Afghanistan or Pakistan, but up in the Indian Himalayas. Liberia is where I've done a lot of my work, and more recently in Haiti. So I'll share a bit how this all came to be. But I actually credit the beginning of my global health journey as starting right here in Johnson City. I grew up here. I went to Science Hill High School. And when I was a sophomore in high school, I participated in an Appalachian Service Project and went out to rural Kentucky and helped repair some rundown trailers that didn't even have running water. And I will say I grew up quite privileged here in Johnson City. And it was really the first sort of eye-opening experience for me about how other people live, seeing poverty firsthand and sort of dealing with that. And it was at that point that I really did decide to dedicate my life to doing something to help people and doing some kind of service. And from there, I actually, in college, I was at Wake Forest undergraduate, and I had the opportunity over 2 Christmas breaks to actually go work with Mother Teresa's Missionaries of Charity. And as the headline from the world-famous Johnson City Press says, this certainly did change my outlook on life and change the way I sort of viewed the world. And yes, that is me as an idealistic 19-year-old young man getting ready to take on the world, standing behind Mother Teresa, which was an incredible experience. And one of the things that I've tried to do is return to the same areas repeatedly. So I actually went back to Calcutta, India for a total of 4 trips, and I went as a medical student and as a resident physician. And it was really a cool part of my career to sort of be able to return to the same region repeatedly, and, you know, as my healthcare career advanced, sort of be able to offer different skill sets as I got more training. And then I got busy with life and career and working here in the U.S. as a pediatric hospitalist, but I always knew I wanted to get back to global health. So I actually, after being a pediatric hospitalist for 4 years, decided to take a 1-year academic sabbatical. And if anybody is ever in your career looking to do an academic sabbatical, if you offer to go as an unpaid sabbatical, that makes it much easier. I was working for a large hospital system, so my university affiliation was not as strong as it is here now, and so I went for a year, saved up my money, and one of the first things I did was study at the Liverpool School of Tropical Medicine, which the tropical medicine course is really very interesting. It's about a third clinical tropical medicine, so learning about all those weird diseases like malaria and Ebola. About a third what we call vector biology and parasitology, so learning about all the different insects and buggies and how parasites are transmitted. And then the third part of it is kind of an introduction to public health. So got pretty good public health training, not nearly as much as you would get with a master's in public health, but it was certainly a pretty good introduction to some of that. It's a 3-month course, but really a very intensive course, like 9 a.m. to 5 p.m. sort of class, Monday through Friday. But a really, really interesting and great experience. And from there, I traveled to West Africa. So this was in 2012. And worked for a smaller non-governmental organization there in and around Liberia. And when I was there, I worked for a public hospital, actually. Again, I was sponsored by this smaller local non-governmental organization, but I worked hand in hand in a very large, busy Ministry of Health public hospital, right on the outskirts of Monrovia, the capital of Liberia. And this is sort of the street view of where I was working. Shanty houses sort of as far as the eye can see. Liberia is one of the poorest countries in the world and remains one of the poorest countries in the world and one of the least well-resourced in terms of numbers of doctors, nurses, et cetera, in the world. And this was the emergency room where I worked with my partner, Dr. Jude, a Ugandan physician who was working there. But a very, very busy emergency room where we saw incredibly sick patients on a daily basis. This gives you an idea of how overcrowded and busy it is. This is one of my resident physicians who was rotating with me there. And part of the reason I point this out to folks is from a public health perspective, you can imagine how and why Ebola was so devastating in West Africa. So you can see 3 babies sharing a crib here. And it would be pretty common that these kids may have different problems. This child may have pneumonia. This child most certainly has severe malnutrition and perhaps has severe diarrhea. And this child could even have meningitis. And they're all sharing the same space. This is also why when people were freaking out in 2014, I was not freaking out because I knew firsthand the conditions were very, very different in West Africa than they are here in the United States. We didn't even have easy access to hand sanitizer and running water much of the time. We brought our own hand sanitizer. If you needed running water, you had to actually exit the emergency room and go to the outside of the building. So you can imagine, again, how an epidemic like Ebola could have such a huge impact on hospitals such as this. And towards the end, I can talk a little bit more about that experience too, but wanted to sort of jump off from my personal journey and talk a little bit about how is healthcare developed in low-resource settings. So certainly there's the government ministries of health often that sort of direct and organize healthcare, but in lower resource settings, there's often all these other agencies involved, and I sort of call this the alphabet soup of global health. We're not going to go through all of this. I do a separate hour-long lecture where we sort of dive into these agencies and try to understand them. But just to give you a quick snapshot of some of the big players in global health, and that includes the UN agencies such as the World Bank, bilateral organizations. So that is when one country provides aid to another country. So the U.S. version of that is USAID. DFID is the British version, for instance. I will talk just briefly about NGOs, or non-governmental organizations, or civil service organizations. Public-private partnerships that sort of try to bring together public groups like the World Health Organization with private industry and with like the Gates Foundation. Academic medical centers such as ETSU have a role to play in all of this as well too. Obviously, faith-based organizations are often involved in delivery of healthcare in low-resource settings, and even the military sometimes provides a role. These are, again, some of the United Nations agencies involved in global health. And again, just for a quick snapshot, this is really, these next few slides are really meant as an introduction and something that you can look into a little bit more if you have a particular interest. But non-governmental organizations or NGOs are often the vehicle which people from the U.S. use to go work abroad. And there's a lot of different kinds of NGOs or non-governmental organizations. And I kind of break them down, at least in my mind, those that do disaster or emergency relief. And perhaps the best known one is MSF, or Médecins Sans Frontières, for those of you who are better at French than I am, or Doctors Without Borders is the other name that people know. Related to that is IRC, or International Rescue Committee, which is another sort of similar organization to MSF. And then there's those NGOs or non-governmental organizations that really work for development. And some of those are large non-governmental organizations. They may be comprehensive, multinational, and examples of that are like Save the Children, the Carter Foundation, or the Clinton Foundation, and they're involved in lots of different aspects of global health, and I'll show you an example of that in a moment. And then there's a lot of sort of smaller NGOs, and I've worked with some of these over the years, and they may just focus on a single issue. So for instance, Operation Smile does cleft lip and cleft palate repair, and that's all they're focused on. They're not necessarily focused a lot on malaria or Ebola. They're focused on repairing cleft lip and cleft palate, which is an important service, but again, they're sort of very much smaller and much more focused. And then there's NGOs that work for a single country or a single project, like the one I worked in Liberia was just focused on work in Liberia and not sort of broad reaching. So there's an example of the Carter Center, which does incredible work worldwide, including being very close to eradicating guinea worm, for instance. And these are some of the programs that they have, and this is half of the countries that they work in. So you can see they work really, really far and wide in terms of different places in the world. And this is an example, again, of sort of a larger, multinational, in many ways comprehensive non-governmental organization. So you may have seen in the title of my slide this term medical tourism. So many people who get started in global health sort of take these trips where they go for a few days or for a week, and they set up a clinic and they see lots of patients. Some people in the medical literature and in conferences I've been to sort of refer to this as medical tourism, which is a term that's really kind of applied to these short-term mission trips that really may benefit us coming from a wealthy nation more than it benefits the patients that we're serving in poorer countries. Bless you. And that's not to be confused with sometimes you'll run across the term medical tourism in the literature that actually refers to people from like the US going to like India or Brazil to get hip repairs. That's a different kind of medical tourism, but that's another kind of medical tourism that happens. This is medical tourism of sort of US and European folks from wealthy nations going to work in poorer countries. So this is not an example of medical tourism, but I bring this up because this is obviously one of the Ebola workers from West Africa. And as I mentioned, I had been to Liberia for a long period of time in 2012, and then returned to 2013 and 2014. And actually, I was getting ready to take my second trip on April 1st of 2014 with 3 of my residents from here in the US who had not been to Liberia before, when a few days before our plane was getting ready to leave for Liberia, we learned of the Ebola outbreak starting in West Africa. And obviously, I could not take my residents into the Ebola hot zone, especially in those very first few early days. So we scrambled at the last minute to figure out what to do. I felt bad I had these 3 residents who were really committed to doing a global health project. And one of them knew of a project in Haiti that they had a friend who they had worked with on. And we made contact with this organization, and lo and behold, they were able to allow us to come for a week at the very last minute. So I was pleased that we were able to do that. Before we left, I actually did a lot of extra training, and we did some interesting cases. And so I tried to give those 3 residents as good a global health experience as I could. But we sort of, at the last minute joined onto this NGO project to do these medical clinics in Haiti. So the 4 of us flew down, and for the first 2 nights, we stayed in this absolutely beautiful house where the non-governmental organization actually owned. They had a few offices in there, but this is where they hosted their volunteers. And you can see my resident physician working hard at global health, sitting around the pool. Actually, they're working on their tan more than on global health. I will say we did do a few lectures out in the courtyard there, poolside. But this is the kind of thing that I talk about when I refer to sort of, quote, medical tourism. And I won't name names of the group that I work with, but I was very concerned that this trip was benefiting us much more than it was benefiting our patients. After a couple of days of relieving our stress at the beautiful hacienda there in Port-au-Prince, to mix languages a bit, we then took off for some rural areas in southeast Haiti. And we certainly, saw a number of patients, but this is sort of the classic medical tourism thing that you'll see people set up clinics in a church, and patients sort of show up. We're in these very rural but very beautiful areas of Haiti. Some of these mountains are actually 8,000 feet high. People forget how mountainous Haiti is. It's actually, some of these mountains are taller than Rome Mountain, which is pretty impressive. But hard to reach areas. But over the course of, we only ended up, despite the fact it was an 8-day trip, only saw patients 4 of those days. We saw a total of 100 patients in 4 days, which sounds like a pretty good number, but when you think about it, these are 4 highly trained physicians. These were all senior resident physicians who were getting ready to practice pediatrics independently within a couple of months. And for 4 of us to see 100 patients in 4 days, that's 25 patients a day. That's really not very much at all. And when you think about the cost of having us all go down on this, trip, which was a lot of fun to be honest, but you really question, is the work that I'm doing helping the local population as much as it's helping me and my residents? And I think, you do have to think about these things critically. I think we do have to sort of self-examine and say, okay, are we doing the right things here? And I think one of the problems with these kind of trips where you fly in for a few days is you often lack integration with the national health system. You may compete with local doctors. So if I'm providing care for free as an American doctor, but there's a doctor down the road who's a Haitian doctor who might charge $1 or so to see a patient for a consult, I'm undermining his practice and his ability to earn a living. And what is he going to do? Well, he may decide to come to the U.S. where he can make a living and further contribute to this idea of brain drain that y'all may have heard about, where people from poorer countries do come to the U.S. For a better living. There's often poor continuity of care with these types of experiences. We had no good medical records. Sometimes patients would show up with things scribbled on scraps of paper, but no good way to tell what to do. And so if you see a 50-year-old man with hypertension and you give him a month's supply of antihypertensives, well, what's he going to do next month? And so these are some of the problems with these kinds of trips. Related to that, there's often poor preventative care. I would have loved to do one of these trips and just get vaccines to everybody, but that's not what this trip was sort of purposed for. It obviously lacks sustainability. And participants from the U.S. who do these kind of trips, they may not be super familiar with local culture, local diseases, or best clinical practices in the country. At least I had a fair amount of experience at that point in global health, and I could prepare my team, and we did lots of extra reading about Haiti at the last minute and try to learn as much as we could. But a lot of teams do just sort of fly in for a week and do what I would call these sort of feel-good trips, and maybe not pay attention to this. And I'll give you a specific example of this. We saw a 30-year-old woman with diabetes. She had type 2 diabetes, which is often controlled by oral medications. However, some well-meaning American doctor had prescribed insulin for her, which when we looked at her records, we decided she really did not need. But she had been carrying around insulin in a cooler for months. She spent a ton of money to get this insulin, and no one had showed her how to use it. She didn't have syringes to inject herself with insulin. She didn't have any devices to check her sugar, yet she had this insulin in a cooler which she had been carrying around for months, and at great expense. And, you can imagine how a well-meaning, hoping to do good American team sort of sweeping in to try to do something, prescribed this medicine for her, which was completely inappropriate. So again, I think we have to be critical when we think about these things. But on the other hand, I do want to point out that often many people start, including myself, doing these short-term medical missions and that that's often how all of us get started in global health. Most people don't just sign up to go work for a year in Somalia, for their first time global health experience. And so I think there is a potential upside. Again, I think as long as you think about these things critically, then I think you can try to do more good than harm. So I think it's really important that we inspire learners and students for future global health trips. I think that's a big part of this. I will say, let's say I didn't go to Haiti for that week and instead I decided to go to Mexico and sit on a beach and sip margaritas and eat tacos. That would be cool. I'd help the Mexican economy, but the Haitian economy struggles a great deal more than the Mexican economy. So if I just thought of this as a tourist trip and I saw some really cool things in Haiti, I had a fun time, well, I did spend my money to support local interpreters, drivers, cooks. We stayed at this hotel, in parentheses, that was in this sort of Haitian tourist destination where no one else was staying, and it was a pretty rundown place, but our money was paying so that we could stay there, and so there may be some benefit to supporting local jobs. Obviously, there's the benefit of some cultural exchange on both sides, and sometimes you do reach isolated, rural, hard-to-reach populations. It took us 7 or 8 hours from Port-au-Prince to get to one of our spots that was really hard to reach over terrible, terrible roads, and sometimes that is the only way that healthcare can be provided in some really hard-to-reach spots in the world. And hopefully some of these trips do some short-term good. But again, I think you have to think about the downsides and sort of weigh those as you work or investigate different projects you may want to do in global health. And this is an example of, again, what another trip that some might label as sort of medical tourism, where I was actually with a group of students and residents in the Indian Himalayas. And this is actually in August, so you can see how much snow this region got. And actually, the area that we were serving, it was a really fun trip. It was with a group called Himalayan Health Exchange, and it was a 60 to 70 mile trek. And we didn't actually cross any roads during that 60 to 70 miles of hiking. But the population that we were working with here is actually snowbound for 8 to 9 months of the year. They can't get out. There's no other way to get healthcare in or out. And so there's opportunity during the summer months, but there's not a road to where a lot of these villages are. You have to hike 30 miles to get there. So in places like that, maybe this is the best we can do for the time being in some of these hard to reach places in the world. I'll pause there for just a minute and we can see how we want to do with some other stuff. But anybody have any questions or comments so far? I can talk about this stuff all day. I can just ramble on for hours. But any questions or comments, we'll do some more things.
You mentioned that ETSU is an academic medical center. Is that an accurate description of ETSU?
That's a good point. I guess we have academic medical programs, certainly. So you're right. Where I was working before, what I'm more classified as an academic medical center, but we certainly have the structure of an academic medical center.
If we had our name on Johnson Medical Center,
correct.
That's kind of okay.
Correct. You're right. You're right. That is an important distinction. So. I'm going to keep going. But feel free to raise your hand if you've got questions or comments. So, I've sort of alluded to the fact that there are many projects throughout the world. And so I do wonder sometimes, is one of the biggest challenge for healthcare for some of the world's poorest populations, the fact that there are so many different groups and agencies, sort of working in these different settings. And the problem with having all these different groups involved is that often there is fragmentation of care projects. There's even duplication a lot of times, a lot of projects doing the same thing. There's often poor coordination among all these different players. There's often sort of a top-down approach where the country doesn't really sort of own what's happening within their own borders. There's all these other groups sort of sweeping in and dictating how things are done. And there's often high transactional costs. So by that I mean it's really expensive to send me and 3 of my resident physicians down to Haiti for a week, as opposed to training local experts there. And there can even be competition among some of these different agencies. So to finally just drive this point home, I'll share with you a story of a little girl I encountered in Redemption Hospital in Liberia. And she's a very sweet 5-year-old girl who came to see me because she had recurrent bouts of fever, was getting lots and lots of fever, and her mom noticed that her belly was swollen. And when I lifted up her shirt, this is what I saw. So this is actually her spleen, which you all may know is an organ that's usually tucked away here underneath the left side of your rib cage, and this is her liver. And the spleen should cut off there, and hers actually was swollen all the way down below her belly button. And this is an entity referred to as tropical splenomegaly, which there's some controversy about causes, and especially in kids it gets complicated, but what I thought may be a player in her was that this, particularly in young kids, there's some literature out there about being an interplay of recurrent malaria infections as well as schistosomiasis. So this is a parasitic fluke, a kind of parasite that you get by swimming in fresh water. And when you swim in fresh water, a form of it actually burrows through your skin, and then it takes up residence and lives in the veins around your intestines. And this is actually a male that sort of enveloped a female, and that's how they live together. And believe it or not, the parasites make sweet love in your intestinal veins. And when they make sweet love in your intestinal veins, they actually shower your body with their eggs. And it's the eggs that get released that are taken up by your liver and spleen and cause this sort of dramatic immune response that can cause this big liver and spleen swelling. And it's classified as a neglected tropical disease, a disease that we haven't fully figured out how to manage and take care of, that affects 200 million people worldwide, so a pretty big player. So just to tell you this a little more about this 5-year-old girl's story, I met her at Redemption Hospital. One of the physician assistants working there for the Ministry of Health came and found me and said, Dr. Jackson, can you help me with this case? That PA had been trained by Doctors Without Borders, MSF, during the Liberian war years. But after the war ended, MSF left the country, and this PA was left without a job. He eventually was able to find a job at Redemption Hospital. That's interesting because he was still following those same protocols from 10 years ago and had not gotten any further training. I was working for a smaller NGO. My partner, Dr. Jude, who I mentioned earlier, Ugandan physician, was working for this group called IRC, a completely different organization. And so it's just interesting, this sort of mishmash of different groups. So Redemption Hospital was sort of built in a very ramshackle fashion. The ward where we were in the emergency room was actually built by Mercy ships. And then you go one building over, and part of it was built by USAID. The ward where kids were recovering, which was built further down around the corner, and again, it was sort of all thrown together, was actually built by the U.S. Navy, of all things. It was called the Navy Ward. And that's where we sent our relatively well kids. So the problem that this child encountered was that to treat schistosomiasis, I needed a particular anti-parasitic called praziquantel, which is not hard to come by here in the U.S., and in fact, my wife is a vet tech, and she has tons of it at all times. But it wasn't in the pharmacy that was run by IRC. I couldn't find it. So I called around to some other places to see if anybody had it, to one other hospitals where I knew folks were working. They didn't have it. I went across the street to the private pharmacy, which was run by local Liberians, and they actually didn't have it either. So I really felt stuck. Now it's interesting because if this young child had HIV or AIDS, she could have gotten state-of-the-art HIV treatment through what's called PEPFAR, which is a U.S. program, the President's Emergency Plan for AIDS Relief, which has been in existence for, close to 12 to 15 years now. It started underneath the Bush administration. So if she had HIV or AIDS, she could have gotten state-of-the-art treatment, but I couldn't get this simple anti-parasitic because she had this neglected tropical disease. So unfortunately, I had to discharge her from the hospital with no further treatment. I treated her for malaria. I said, maybe check back with us later, but I had no other options to offer this young child. And the frustrating thing about this case was 3 weeks later, I was walking through the hospital and went to go see a patient on the adult side of the hospital and walked by the adult pharmacy. And lo and behold, there was a huge bottle of praziquantel, the anti-parasitic that I needed. It was sitting right there. But I had no idea because the pharmacies were run by 2 different agencies and they didn't talk to each other. So again, that's one of the frustrations and how this fragmentation of care in lower resource countries can be problematic. To sort of wrap up, a little bit more, I wanted to just introduce you to some of the current global challenges and possible solutions. And again, this is meant as just a taster, a little bit of an introduction. And if you're interested in this stuff, you can definitely go online and read more. One of the cool things about global health is there's a lot of free information available online. So a lot of this is published as free literature, and a lot of the stuff that comes out from the UN now is all online. You can read their budgets, you can see where the money goes. So it's a very easy thing to research if you're interested to learn more. But I think a good starting point, if you want to know a little bit about what are some of the issues in global health today, is starting by looking at the Millennium Development Goals and what are now the Sustainable Development Goals. And then we'll talk a little bit about just some individual steps you can take to be responsible or informed global health workers. So the Millennium Development Goals started in 2000, and they sort of had 8 big goals, that they were looking at to target in the world, and that includes, targeting poverty and hunger, gender equality, child health, maternal health, and really big focus on HIV and AIDS. And that's, again, where we were sort of in the year 2000, and try to set targets for how we can do better by 2015. So as a pediatrician, one of the things I care about a lot, of course, is young children dying. And so the 4th Millennium Development Goal was how can we reduce child mortality of young children under the age of 5 by 2/3, so cut that number by 2/3. In many parts of the world, including in Liberia, for instance, when the targets were developed, or the initial baseline data for Liberia from 1990, Liberia had nearly 250 out of 1,000 kids dying before their 5th birthday. So that's 1 in 4 children dying before their 5th birthday, if you can imagine what that's like. So the Millennium Development Goals were to try to cut that number by 2/3. But to understand that, you have to understand a bit about why do children under the age of 5 die. And I'm going to skip this one. This is the most up-to-date graph, but it's a little bit busy. And I want to go to a simpler one. And you can see there's a little bit older data, but I think it's a little more helpful to understand. A lot of the causes happen in the neonatal period, or the first month of life, and in fact, that part of the pie is even getting bigger, and so there's more attention being paid to that. But you can see malaria and measles, for instance, and again, these numbers have shrunk as of late, but still really big players. But common things that we don't necessarily think about are what often kills kids under the age of 5, things like diarrhea and pneumonia. And that's often due to lack of access to health care. But the other big player in this, and this is why I prefer this pie graph to the other, is you'll notice in the center is malnutrition, which is often the biggest driving force of all of these. And malnutrition impacts all of these causes, and is certainly present in at least 50%, and sometimes in some settings up to 60 to 70% of the causes of child death of under 5-year-olds. And again, just to give you a little bit of a snapshot, this is the percentage of causes of deaths for children under 5, not the absolute numbers, but the percentages. And you can see in the US compared to Liberia, where you're dealing with a lot more things like malaria and respiratory infections. But there is good news. We did not reach the Millennium Development Goal of reducing child mortality by 2/3, but we cut it by more than half. So that's super impressive. And when you think about this is the absolute number of deaths worldwide for children under the age of 5, starting in 1960 and going all down to 2015. And you can see we've really accelerated our progress in this as well too. But this is impressive, especially as you think about the world's population continuing to grow and rise, that we've cut child mortality by more than half. So we really are making good strides. Probably one of the biggest players in this is vaccination. The Gates Foundation, there's a nice quote that if you want to know what the best investment of your dollars is in global health, it's child health. If you want to know the best bang for your buck within child health, it's vaccination. As a pediatrician, I certainly agree with that. So. But it's not all good news. Despite many successes, and this was the conclusion of the Millennium Development Goals report, the poorest and most vulnerable people are being left behind, and I think that is still true. So now we have these things called Sustainable Development Goals, and again, this is another area if you're interested. There's sort of short versions of these reports that are 20 or 30 pages, or if you're super nerdy and interested, there's like 200-page documents. Probably the more digestible ones are easier to recognize because these are very broad-based, and this is kind of this is the United Nations, by the way, trying to sort of set what the international global health agenda is. And now we have much more 17 broad-based goals, where the Millennium Development Goals was sort of focused on 8 areas, with 169 more specific targets. So it's a little bit overwhelming. But targets are set for 2030. And areas that they're really focused on are people, the planet, prosperity, peace, and partnership. They really like those P's for some reason. Focusing again on child health, what they actually did was they said we want to ensure healthy living for children of all ages. And actually, whereas the Millennium Development Goal was trying to cut it down by a percentage amount, they actually say let's try to get all children under the age of 5 so that there's mortality less than 25 per 1,000 live births. Again, there are still parts in the world, I don't know if there's parts in the world where that number is still 200 per 1,000, but there's certainly parts of the world where over 100 children per 1,000 die before their 5th birthday. So we've got a long ways to go, but that's sort of the goal that we're sort of reaching for in child health. And in fact, this is, again, I told you I was a map nerd, I warned you of that. If you look, these are areas of the world that need to get to that goal of less than 25 children per 1,000 dying before their 5th birthday. And you'd see the areas are blue is where that goal has been reached. But areas in red are places where if current trends continue, they are not going to reach that goal until well beyond 2050. Or places in orange or brown are areas that it's going to take them a while to get to that goal. So again, I think that that's important to keep in mind. I did also notice, looking at this map, that for instance, Syria is in blue, and I very much doubt that that's still the case. So that also points out one of the challenges for public health workers is getting good data and keeping it up to date, which is certainly an issue. And again, I sort of mentioned the Millennium Development Goals, really very focused on HIV/AIDS, and the Sustainable Development Goals, for better or worse, have this very sort of broad view, looking at not only HIV/AIDS, but tuberculosis, malaria, neglected tropical diseases, hepatitis, and lots of other things. And this is a list of the neglected tropical diseases. I, again, alluded to schistosomiasis that I think my patient had in Liberia. But these are some of the other sort of exotic diseases that people think about, but one of the targets for global health. So the Sustainable Development Goals, I think they're still new. I think people are still figuring out how these are going to work. They are much more broad, much more far-reaching. Some might say overly ambitious, but I think it's good for us to have those targets to work towards. It's interesting rereading them for this talk. I noticed there is much more emphasis on the environment and economic development as well too. But hopefully they will help to sustain our interest and international attention to these important issues. And finally, I would be remiss in a talk about current affairs of global health if I were not to mention the current refugee crisis that we face worldwide. So without getting into the politics of it, one of the facts right now is that there are more refugees and displaced people worldwide than there's ever been in our known history. So there are over 65 million people, nearly 1 in 100 human beings, many of them children, who are displaced or refugees or fleeing war-torn areas. And so this is an alarming number, and we have not figured out how to deal with this adequately yet. But this is perhaps, if not the biggest, one of the biggest issues in global health right now today. So if I were to summarize sort of some of the challenges worldwide for global health in 2017, again, I sort of introduced you the Millennium Development Goals. We made so much progress, and I think the Millennium Development Goals help to drive the international community forward, but we still have a really long ways to go too. And the question is, will the Sustainable Development Goals do a better job of that? There's also this fragmentation of projects, and I sort of mentioned that, all these non-governmental organizations sort of swooping in and doing different things. I think the other big issue too is we continue to focus as an international community on disaster relief rather than sort of prevention and strengthening healthcare systems at their core. Again, I mentioned the refugee crisis, and I think one of the biggest challenges we face is all of this is dependent on funding from wealthy nations. We talk about world global health. And the U.S. is the biggest funder of many of these projects. And the question is, with the rise of nationalism and isolationism, not just here in the US, but also in many parts of Europe, what's going to happen to funding for global health projects? And I think much of that is up in the air. There's already been talk in Washington, D.C. of cutting funding to USAID, which is the American sort of relief agency that provides funding to many poorer parts of the world. And so what happens if that funding does get cut? So stay tuned. And this is a challenging time for global health, and I think it'll be interesting to see how this all unfolds. So final part of the talk, home stretch, I promise. I think I'll skip one part of this, but I do want to just get to the part about when you are thinking about doing a global health trip, or if you think about a medical mission, what sort of things do you need to think about to be responsible and sort of well-informed? I'm going to skip this part, which is a little bit about our academic medical collaboratives that have worked in low-resource settings. All I'll say about this is that this is one way that I've done global health that I'm sort of a proponent of. I give you some of the pros and cons, but it's a way that U.S. medical students and residents can participate in global health but be part of a larger project. And we actually work quite a bit in the collaboratives I've worked in both Liberia and Haiti to not only do direct healthcare, but to help with quality improvement, with how the hospital flows, and perhaps most importantly, and one of the things that I really enjoyed is lecturing medical students and residents in Liberia and in Haiti, and doing clinical rounds with them, just like I would here at the hospital at Johnson State Medical Center. So I'm going to skip through that for the sake of time, and just go straight to how can we be well-informed global health workers. So if you're thinking about working at the non-governmental organization or thinking about going on a mission trip, these are some things to think about. I think, first of all, does the organization work well and for local partners? Is there a true partnership with local populations? Has a needs assessment been done? And are you integrated with the National Ministry of Health? And perhaps most importantly, are you invited to work in that region? Has someone signed off on you coming? They know that you're coming and they're part of a local team, rather than just flying in and setting up the tents and again, being cautious a little bit of some of those quote feel-good trips. And some people even argue you should be licensed. I had a medical license from the Liberian Medical Board when I worked there for a longer period of time. I actually had to do an interview and everything. So I think when you can do that, that's really important as well too. Is the group you're working with responsible with funds? Is there transparency? I mean, this stuff really should all be out there. You can go to the Bill and Melinda Gates Foundation right now online, and you can see where they spent every penny, down to a $50 donation to a small local high school. So I think that that's really important, and I think that's where things are going. Does the NGO work well with other NGOs? Some are very territorial and don't tend to work well with other partners, but that's one of the things I like doing when I go there. It's like, hey, I see you're working at this group. What are you guys doing? Hey, maybe we can partner together and work on this project together, rather than competing with each other. And being thoughtful about, is there continuity of workforce and funds? When your team of doctors leaves, is there someone else who's going to take up the work after you're gone? And thinking a lot, not just about doing direct hands-on care, but is there the possibility for capacity building? Are you helping with education and training of future doctors or future students? Is there quality improvement work to improve how the healthcare system functions? And if you want to read more about this, this is one of the articles that I particularly like on this subject. And it was written from the perspective of healthcare workers, I believe, in Namibia. And they were interviewed, and they were sort of asked in a sort of semi-structured interview sort of setting, like, how do you feel about all these, rich Americans coming and working in your hospital? What's your perception of them? And the things that they thought were really important for Americans coming to work in their healthcare system was that people see cultural and environmental context before travel. So doing pre-departure preparation, I'll talk a little bit about that in a second. That there is a long-term relationship for mutual benefit. That there is a formal needs assessment. So again, you're being responsive to the needs and learning what local populations think is really important. And are you traveling with respect, humility, and a desire to learn from local partners? And those were sort of the four big themes from that particular study, which I think is really important to keep in mind. And I love this quote, which came directly from some of the interviews, which is, They learn from them, but they also learn from us. So I think going in with that sense of humility is of key importance. And if you really get interested in this stuff, this is a larger study that really goes through some of the ethical principles of all of this. So I think really important when you do this kind of work to again, first educate yourself, learn about the local culture, learn about the local history and politics. I tend to do tons of reading before I go overseas, and it's not just because I'm a nerd. It's actually really interesting stuff, and it enhances your entire experience. I often will try to read a novel or two or a nonfiction piece of work from a particular country before I go there, and again, it just enriches your entire experience. And that's equally as important as learning about the diseases that you're going to see. If you've never taken care of malaria before, you really need to read up on that. If you've never heard of Schistosomiasis before, go learn about that. And there's a lot of resources out there, whether through the World Health Organization or through the Centers for Disease Control, where you can learn more about these things. And hopefully this is not a dated reference, but I think be careful about going in like how many people perceive Americans, which is Rambo with guns blazing. It's really important to sort of put aside our often very highly developed American and Western arrogance and be humble, learn first, share ideas, and be open to the needs and desires of your local partners. And that's perhaps the most important message of all of this. Even when I first went to Liberia, I had been a faculty physician here in the U.S. for 5 years or so, and I had just done this, highly regarded tropical medicine course in Liverpool. I had had hours of lectures on malaria. I knew all of this stuff, but in my medical career, I had only taken care of one patient with malaria. So I did have to sort of go in, and I had all this great book knowledge, but I did go in and I said to the Liberian doctors who were working there, hey, how do you manage malaria? Teach me, let me know how this is different than what I might do in the United States, because often the management is different because they may not have all the medicines there that we have here in the U.S. And so I think it's really important to go in with that sense of humility and willingness to learn some new skills. I think really important to return to the same region area if you can, and I've tried to do that as much as possible, but I've struggled, for instance, to get back to Liberia because it's not a good setting still to take my residents and medical students. And again, I think continuing to work on your personal development if you get interested in this stuff. And I continue to question my current practice and say, am I doing this right? Is there a way I can do this better? Is there a way that this organization can do things better to sort of serve the needs of local populations? And as you all are thinking about as public health students, and if you have an interest in global health, there's a lot of different ways that you can get involved in global health. MSF, again, Doctors Without Borders, IRC, International Rescue Committee, all great organizations. These are some other non-governmental organizations that I would certainly recommend that all have a good track record. There's obviously university-based work, bilateral agencies. I mentioned USAID. When I was sort of researching for this talk, the CDC has a lot of options for public health students, and some of those are international options as well too. And then, further in your career, this is usually not somewhere where people start, but further in your career, think about work with UN agencies. And when I was thinking about possible roles that people in the public health school might do in global health, some of the opportunities are to do needs assessments, research, data collection, outbreak investigation. So when a disease does happen, investigating that, helping figure out what to do next, logistics, consultation, education, and healthcare deployment. So final take-home points, global health does affect us all. Care of global underserved populations is improving, but progress is uneven and frequently care is fragmented. I think we need to continue to work to evaluate and refine our current models of global health and how can we do this better. And of course, I'll end with a couple of pictures. This is me with my residents in Liberia, and much more with my residents in Haiti. This was a different trip than the first one I described. And I can't end a talk on global health without showing you a picture of smiling boys trying to get that picture taken. Although this poor guy in the front, I think he just got decked. But boys will be boys, no matter where you go in the world. So thanks, y'all. Appreciate your time.
Thank you. So I'm going to turn on the light, and maybe that will help with The group here, let's see if that was more.
And by the way, I'm glad to talk about any of my experiences working overseas, global health in general, or if y'all just want to know a little bit more about my work as a pediatrician here in the US, I can also share a bit about that.
So we have about, 10 minutes for Q&A, and if you don't, ask a question or make a comment, I will, so I'm going to keep you so go ahead.
Yes, ma'am. There in the front.
Thanks, Jackson, great talk. So I think it was really helpful that you provided some opportunities broadly, but what are some ways maybe students locally can interface with you in the College of Medicine if they're interested in going to medical school or things going on here that you're trying to set up? Can you talk a little bit about that?
Sure, absolutely. So I'm definitely on ETSU email, and Dr. Corey can definitely send that out as well, so I'm glad for folks to have my email. So glad to have anybody write to me if you're more interested in either pediatrics or global health. One of the things, and Dr. Quinn and I are sort of in the process of really developing global health here at the university, and we have this really great sort of interdisciplinary group that's working on all of this. But much of our work that we're doing right now is still in development. I will say, and I'd be curious how you got started too, a lot of times it is just word of mouth, hearing about different projects from different people. I will say, again, a lot of this stuff is online, so you can do pretty good research, although I've never found a single website place where you can just find global health opportunities. But again, think about some of those things I said about different organizations. I will say that list of what to look for in a non-governmental organization. I've not seen any organization do this perfectly well, even the best ones in the world. So, for instance, Doctors Without Borders, which I consider to be one of the best global health groups in the world. They do incredible work. My wife and I still donate to them on a regular basis. I've had lots and lots of friends work with them over the years, but they don't always work well with other NGOs. They tend to sort of play in their own little sandbox and don't really partner as well. And sometimes they've had challenges with transitioning their care. So they go into a crisis, they work somewhere like Syria, where very few other agencies are working right now, but once the shooting stops, they kind of tend to be like, okay, we'll see y'all, good luck with things. And that's one of the critiques of Doctors Without Borders. But again, I just point that out because I consider them to be one of the, again, best groups in the world, but they don't do all of this perfectly either. So you have to take this with a grain of salt, but this is a good list to sort of, at least if you're researching stuff online or you hear about a project from a friend, you can certainly do that. But again, I'm certainly glad to have folks email me and discuss a little bit further stuff. One organization that I do know folks can get involved with, usually at the graduate level, but occasionally we have undergraduates too, is the Himalayan Health Exchange group that you saw that picture. And by the way, doesn't always look like a snow blizzard on that trip. That was the most dramatic picture from that trip. But that's a pretty good organization that does have students go on a regular basis. It is really expensive, but they've been working since the late 90s in the Indian Himalayas, and it is sort of locally run and operated. So that's one group that I can recommend certainly on that.
Yeah, I think it's just always hard to figure out how to get started. So.
It really is, and often if you make connections with someone like myself or Dr. Quinn, we can at least get you started or potentially, have you talk to other people. But you're right, it's a little bit of a challenging field to break into those first few trips and experiences you have. Most of what I've found out has been talking to someone who knew someone or had been on a particular experience and then following up with that. Other questions?
Megan, do you know how much quickly about the Peace Corps?
Oh, sure. So we, in the College of Public Health, we recently got a partnership with the Peace Corps. So undergraduate students can go, we have a connection with our local Peace Corps recruiter, so we can plug you in with that person, Deborah Buckley. And so then once you go into the Peace Corps and serve for your 27 months, you can come back to ETSU and get a master's degree in public health and any of our concentrations. So health services management policy, epidemiology, biostatistics, environmental health, or community and behavioral health. And that program is partially funded for your MPH. So it's a good opportunity if any of you guys are interested in global health work. The Peace Corps does open a lot of doors, but it's a lot of hard work for 27 months, so it has to be something you're pretty committed to. I would recommend doing your field placement in global health, see how you feel about it, then go to the Peace Corps, and then come back and get your MPH stuff.
That would be a very good career path, definitely.
And so for the field placement, one of the options is.
Right, so the field for international, particularly for undergraduate students, we've limited that to just a few partners. We do ask that you travel pairs. You have to have at least 2 students to work with, unless you have significant global experience already. For undergraduate, we'll probably say you have to go pairs. Graduate, we've had some exceptions to that. Again, that was for significant experience. The partnerships are limited to, well, there's 3 sites now, right? The Belize site, which is in Central America. It's an English-speaking nation. There's a hospital there. We have Project Hope in South Africa, and if you speak Spanish, we have a site in the Dominican Republic. That had to be fluent Spanish to get that site.
And as it turns out, partially through the connections with Dr. Quinn, I'm actually checking out the site in Belize, and there's a pediatrician there who may be willing to work with my resident physicians and maybe even my students. So I'm traveling there in May to see if that's a good opportunity. As much as I'm passionate about the work in Liberia and Haiti, those are places I generally wouldn't send undergraduate students. But again, it's been sort of primarily involved in clinical education, so those can be good experiences for resident physicians after you've got this first one.
And to add to that, part of the reason we picked those 3 sites is they've all been checked out. They're safe sites. We know where you kind of stay. And we've sent lots of students to those particular places except for Belize because it's a new partnership. But that's kind of why we can't send students to any places on the U.S. State Department watch list, which unfortunately Haiti is, and I'm not sure if Liberia
Liberia's
is
not
right now
anymore.
or not.
During
Yeah,
the Ebola
okay.
outbreak, it was being opened up.
Yeah, that's what I thought. So
It's no longer on the watch list.
anyway, something to think about if this talk inspires you.
There is some funding available for scholarships to do that. It's limited, and you're still going to have to fund a portion of that yourself, so keep that in mind.
But there's some funding through our college, and then there's some funding through the international office as well. So you can apply for both sources of funding if you're interested in doing a global experience for your internship experience.
And I will just say parenthetically, again, I sort of shared with y'all, I grew up here in Johnson City, but the most important life experiences of my entire life have been traveling abroad. And it changes the entire way you see the world. You have a different view and understanding of things when you see things on the news, read things online. And I just think I can't stress enough how important doing some kind of travel somewhere where you don't speak the language or you're not familiar with the culture is important. It's been one of the most rewarding parts of my life so far.
Probably made you a better pediatrician here, I bet.
It does actually. Actually, we had a case of malaria at Nightwater Children's Hospital 6 months ago, and all the residents called me up. I wasn't on call, but they were like, "Oh my gosh, we have a case of malaria. Can you come see them?" So anyways, yes. Not to sound arrogant, but I suspect I've seen more cases of pediatric malaria than anybody else in the region. Probably, unless there's someone else out there who's gone to work with Doctors Without Borders or someone else for a long period of time. Any questions? Yes.
Okay. Do you partner with the government agencies too? Because I discovered that most of the issues affecting most of those countries, it's not that they do not have resources, but they do not channel those resources to the right places.
Right.
Do you partner with them to, in one way or the other, provide the social determinants of health?
Sure, absolutely. Exactly. And again, I'm more of an acute care clinical practitioner who's got a lot of interest in global health. So often I have been sort of more involved in the trenches of delivery of healthcare. But you're right. I mean, one of the other big challenges is, to be honest, many governments are corrupt. Some argue that the American government has a fair amount of corruption too. But you're right. In many lower resource countries, the money doesn't get to the people the way that it should. And it is interesting. I will say, I was working for a non-governmental organization, but I was in the trenches in a government hospital, and that does give you quite a bit of insight into how these things run and operate. And I do think some of the best projects try to transition that. So IRC, that I was sort of not working for, but worked very closely with when I was there, had a sort of 3-year plan of Redemption Hospital to sort of transition so that the government was sort of taking over all aspects of pediatric care. And they tried to make it gradual, and they tried to do it in steps, and sort of train people, okay, this is how you procure this antibiotic, this is how you work out this part of the logistics. And I must say, I visited Redemption Hospital after IRC had finished their mission. And so I saw them over several trips as they were sort of making this transition. And when I went back the last time, IRC was no longer there, and things were not running really as well. And we had many more shortages of supplies. We struggled to get a lot of the supplies and medications that we needed. Me and my residents would often buy things at the pharmacy across the street, which was pretty well stocked, but it was a private pharmacy that was run as a business. So you're right, those challenges do remain. There are organizations that consult, like the World Bank and World Health Organization, on how to strengthen these things, and I think they've met with variable success. But you're right, that remains a big challenge. Yeah. Are we at the time?
So to me, so I was born, I grew up in Lebanon, and I saw the name of the country up there on the list. So, I mean, there are lots of good people, but there's also a lot of corruption, right? Yeah. And I think what I would describe as sometimes a lack of will. Because to me, when there's a will, there's a way. And sometimes it's a lack of will to get those resources where they're needed for reasons that you mentioned.
I'm just saying that it's quite challenging, especially when you see malnutrition is in the first, about 54%. Most of this, Nigeria is on the list.
Yes.
Yeah, I can't say Nigeria is a poor country, but the resources do not get to where they're supposed to.
Well, Nigeria, and what we're seeing a lot now, and this is true in Nigeria, India, and other parts of the world, and South Africa, for instance, there are people who are very wealthy and who have all the things that we have here in America, but then there's great health disparities, and there's still people dying of malnutrition on a regular basis. And how do you bridge that divide between the wealthy and the poor? No one in human society has quite figured that one out yet. That's definitely a question for the ages, without a doubt. And I will say, in terms of some of the corruption and things, I'm very sympathetic. I don't want to be a total apologist, but many people struggle to make it day to day in these countries. My Liberian nurses got paid $100 a month to work in incredibly hard conditions. So they made a little bit more than $1,000 a year. And they had to support their own families. They had their own kids at home. So I would get frustrated when supplies got stolen from the hospital that I had brought. But on the other hand, I was like, these people are living on pennies to support their own families. And in fact, the nurses at Redemption Hospital, after I left and my residents were still there, went on strike. And they had to close the hospital. And again, I think, oh my gosh, all those kids don't have anywhere to go. All these kids are going to end up dying. But then on the other hand, I'm sympathetic to the nurses who are making only $100 a month. So there's a lot of challenges out there. I sort of tipped on the tip of the iceberg. There's a lot more that you can dive into if you get interested in this stuff. Thank you.
So thank you all. I think there were a couple more questions, but we are, out.
I'll hang out. I don't have anywhere to go.
So